Hello, everyone. I know some of you are still connecting your audio and everything else, and there's still people who are joining. So I'm just going to give everybody a moment. Good. Okay, so since there's still people who are joining, and I'm really bad at admitting people while I'm talking and going through things, I'm just going to do some general housekeeping. So we're going to do NHS Hot Topics today, which is hopefully what you're expecting to do. Most of you will know me from yesterday. My name is Anna. I teach UCAT and interviews, but just a lot of interviews, really. And today we're doing NHS Hot Topics. We did medical ethics yesterday. Thank you to everybody who came along. It was such a good session. You guys are so interactive and it's really, really lovely to teach you. So for today, we'll do hot topics and I'll give you guys a bit of a choice of what we cover because we have two options and I think we definitely won't have time to do both. But those of you who are attending here right now will be given a choice because I can't ask anybody else. So, okay, I'm going to give you a poll. I'm going to give you a moment to fill it in. But you've got a choice. We can either cover junior doctor strikes or we can cover COVID-19 and vaccine hesitancy. It's entirely up to you. The other one will be covered in a future session, but that will be kind of as part of the teaching. So it won't be part of our kind of introduction to interview series. We'll cover the basics of hot topics anyway, okay? But we really don't have time to do both properly. And I think you guys might have noticed I don't really like doing things halfway. I'd much rather you understand something fully than we just do things kind of a tiny bit here and there. Because I don't think it benefits you as much. Medical school interviews really test if you can understand the topic, if you're kind of aware of things around, if you can think through it, if you can make logical conclusions, if you have a depth of knowledge as well as a breadth of knowledge. So I don't think there's much benefit to doing things halfway. Okay, any last answers in the poll now? Ooh. Okay, it was almost 50-50, but now we've got a bit more of a clear preference. Okay, then I'm going to end the poll. You've said that you'd rather cover junior doctor strikes, so that's what we'll do. We'll cover COVID-19 and vaccine hesitancy in a future session. It won't be part of the kind of introduction to medical school interviews thing. It will be part of something else. We'll do a teaching series that you guys can sign up for if you want to. And we'll cover kind of common topics in medical school interviews, things like, for example, COVID-19 vaccine hesitancy, because they still come up in questions all the time. So, okay, then that's decided, but we'll still start with the basics nonetheless. And what are our basics? Our basics are, first of all, what are our hot topics? I've given you kind of two things already, okay? But what do we really mean by hot topic? Again, you can use the chat to answer things. I won't, if you send things directly to me, and in general, I won't read out people's names, by the way, because this is being recorded for other people as well. But anything that you can think of, yeah. So topics are currently very relevant within the healthcare and within healthcare or the NHS. Yeah. So anything that we consider to be kind of a current issue, okay? So let's collect some. Let's collect ideas. What do you guys think is a hot topic in medicine right now? It doesn't have to be the NHS specifically, but in general in medicine, what do we think is a hot topic other than, I'll give you strikes because we've already discussed that and we've given you COVID-19 and vaccination. Anything else we can think of that might come up that you might be asked about an interview or that's currently happening in the NHS? Good. AI in medicine is a big one. Yeah, so I've got some examples of other conditions as well, but emerging diseases. So not anyone specific, no, they won't ask about a specific disease, but they might ask you about like, what do you think about kind of new emerging diseases? Such as things like Mpox. There are some others as well, unfortunately. There's always new things. Gene editing is a good one. Good. Lucy Letby, so you said this is slightly older. It's not older at all. So Lucy Letby is very, very topical, and you might be asked about it at an interview, but more about kind of the consequences of this and kind of learning points from it. You won't be asked like the hard facts about the case. This is also kind of comes with ethics sometimes. It's a really good one. Good. Obesity. Aging population is a really big one. So aging population, you have been asked, like this is a topic that's been a topic for about 15 years in medical school interviews, and it comes up every single year because it's a really safe question to ask people because everybody should know something about it. So the aging population, although it sounds boring, really, really big kind of topic in medical school interviews. Antibiotics and antimicrobial resistance. So not just antibiotics, but yes. Sugar tax slightly older, but can still come up, yeah. I'll put this one in brackets because it gets asked about a lot more in dentistry interviews. Good, so new healthcare roles is a really big one. It includes changes to pharmacists being able to prescribe, for example, which is kind of an older change as well, but new roles in healthcare. So for example, physicians associates and so on. Good, the new really expensive drugs, new drugs, and that includes biologics and personalized therapies. Running out of space. You guys are really good. Yeah, good PAs goes with new healthcare roles, so that can include PAs. Understaffing, good. Understaffing is always an issue. And it goes with new with recruitment and increasing number of doctors. This is a really big topic for the government. Good. NHS apprenticeship, again, goes with new healthcare roles, kind of, because it's just a change in how we recruit, but good. NHS apprenticeships. Telemedicine, yes. So telemedicine, also a really big one. Okay. I had a question, what's biologically personalized therapies? So these are just new therapies that we're using to treat patients. You don't need to know much about them, but we might be doing a future session about them. I'm a MB PhD student, which means I'm doing a PhD as part of my medical degree. And that means I work a lot in my field. I work a lot with biologics, for example, which are just kind of biological therapies. They're based on your body's immune system and they interfere directly with cytokines in your body's immune system. It's very interesting. I think, well, I have to think. I'm doing a PhD on it, but very, very interesting. But you don't need to know details about it. You just kind of need to know the implications and the kind of ethics of it and why it might be a big topic for us. So we can do a future session on this as well. Good. So increase the number of medical school places. That goes with kind of the understaffing and recruitment part of this. I had a question, which hot topics do you recommend we start with? So that's a good question. We'll discover that. We'll kind of discuss a bit more about that at the end. Okay. But this is just a not entirely comprehensive list, but a very good list to start with of the things that we can be looking at. Okay. We'll cover some of these in future sessions as well. Okay, you're not expected to do all of this by yourself, but they are quite good places to start because many of them are transferable and you should know a little bit about most or all of these. Okay, some of them are a bit more topical than others. So strikes, for example, vaccination, AI in medicine is a really big one this year. The Lucy Letby case, aging population, obesity is always a thing that comes up. Antimicrobial resistance as well, less so the sugar tax, that's more a dentist thing. New healthcare roles, they can ask you about in conjunction with understaffing, and telemedicine does come up as well. The others you get asked about more or are things like that for you to bring up in more open questions, because they usually don't ask you directly about new drugs, but it comes up in ethics, for example. But good, really, really good list. Any questions on this so far, other than kind of where to start? Or anything that doesn't make sense to people? It's quite important that you just are aware of what there is to know. For me, because I think one thing that when I was applying was quite unclear because we had a lot less resources back when I applied, which makes me sound old. But it just wasn't like a list of things to know. Is there anything I would add to the list? Nothing major really. There's some things in terms of ethics that I would add. But no, nothing major. I think these are all the key points. I think with understaffing, the other thing I would really add is the GP shortage, because I think that's quite a pressing issue. And many of the people who will be interviewing you will be GPs. So it's something nice to bring up as well as GP shortage. But I think that's the big ones. There's also kind of some things about prescribing of, but there's some topics that can come up, but you don't get asked about directly. So I wouldn't worry about them right now. Good. So those are your kind of overall hot topics that we're looking at. Now, I'm sorry, but we're going to bore you with some background knowledge on the NHS and kind of some key points here. I know this isn't exciting. I'm aware of that, but it is important for you guys to know. And as always, you'll get a handout. So I'm not asking you to remember any of this right now or to note it down. You can put it on a flashcard, you can memorize it, but some of these are important for you guys to know, and some of these are not so much important for you to memorize, but just are good for background knowledge as well. Okay, we'll start with the bits that are a bit more interesting, but kind of less important for you guys to actually memorize, but interesting for context. So these are questions to you. Who can guess the figures for any of this? So the number of unfilled vacancies in the NHS, any idea of what the figure for that is? These can be blind guesses. You can send it directly to me if you don't want to send it to everybody, but I'm just looking for a number of what you think. How many, this is anybody, this is not just doctors, by the way, this is anybody from kind of admin people, all the way to doctors, porters. Good, I've got some guesses that are quite close. Good. Some of you are very optimistic about this. Some of you are very pessimistic about it. But some of you are kind of spot on. Good. That's another one that's really good. Yeah. So, for some of you, this will come as a huge shock, but it's 110,000 unfilled posts. Now, some of these are kind of temporarily filled. Anybody know what a locum is? Or what we mean by locum staff? Yeah, it's agency staff. So it's people who don't have a permanent contract with the NHS for that job. They're kind of paid a higher rate to fill in a role. And usually this is paid as a premium, which means it's really expensive to have locum staff there, especially if there's a lot of locum staff. So doctors who do locum work, for example, sometimes get paid 1.5 times their wage or 2 times their wage or even 3 times their wage for filling a locum shift. Okay. Same goes for other roles within the NHS. They're basically, like you said, a substitute for something. But it's really tricky with locum staff because you do pay them a bit more, and also because it's not a permanent job for them, so they're often a lot less able to do the same volume of work as somebody who permanently works in a ward, for example, because they don't know the ward as well, they don't know the patients as well, they don't know the other doctors or nurses or healthcare assistants as much. So it can be really tricky. Good. Now, next one, urgent referral 2-week target. So what do you think? So this is cancer referrals. These are people who have suspected cancer. How many of them do you think, what percentage do you think of patients who have gotten an urgent cancer referral, which is within 2 weeks, get seen within 2 weeks by a specialist? Ooh, some of you are pessimistic about this. Ooh, it's not quite as bad as some of you think, I promise you. It's not great, but it's not as bad as you think. So all of you so far have guessed a number that's lower than the actual number. Yeah, so one person is spot on. So this is 80.3% right now. So these are people who have suspected cancer. So for example, bowel cancer or skin cancer, kind of 2 big ones, where it's a 2-week referral. So within 2 weeks, they should get seen by a specialist in the specialty that they've been referred to. So if you have suspected bowel cancer, for example, you should be seen by a gastroenterologist or a general surgeon about that, or an oncologist. But for about 80% of patients right now, that happens, okay? Now, this, of course, is a bit risky if the number is low, because you want people to be seen by doctors as soon as possible if they have suspected cancer, because it can be quite urgent. And this really varies where in the country you are. is something that's kind of important to be aware of, because in some regions it's a lot worse than others. Okay, some doctors, some areas of the country have a lot more shortages of certain specialties than others. And if that's something you're interested in, or if there's a university you like really, really want to go to for your interviews, then you can always look up kind of in that area. You can often find statistics, so you can look up the NHS trust that it's in, and you can look up kind of, for example, I would look up Greater Glasgow and Clyde, and then I would look up kind of unfilled posts or vacancies or referral targets, things like that. Okay, and you can find specific information for the region. And if you can use that in your interview, if you can bring that up, you will always, always, always make a really good impression, and you will seem really prepared and like you really want to go to that specific university. So yeah, that's kind of my suggestion to you as kind of like a bonus point for your interviews. Good. So I hope you are positively surprised by that number, because I think no one guessed a higher number than this. So what do you think is the cost of training a medical student? So that means from first year all the way until they become a doctor. What do you think is the total cost of that? Some of you are really close. Good. Any more guesses? Yeah, so very close, many of you, very, very close. So it's estimated to be about £250,000 for one medical student. And you have to imagine there are thousands of medical students across the country. Now, of course, some of this is then covered by student loans. So some of this the students pay themselves. Some of it is covered by the NHS, but the NHS is funded by the government. So still this cost kind of comes back to the government. Some of it is funded by grants and other things. So not all of it is covered by the government themselves, but it's still very expensive to train a medical student to be a doctor. So this is quite a high cost. But then about £50,000 of that are covered by the student themselves. And then some of it is covered by NHS bursaries and so on. But again, that money has to come from somewhere. Very good question. Why is it so expensive? Well, you have to pay a university, first of all. You have to pay a teaching staff at the university. And medicine is a course of a lot of contact hours, which means there's a lot of hours that you actually spend at the university being taught. And you have to pay all these people. So in first year, for example, less so now because I'm doing my PhD, but in first year, I had a tutor for vocational skills, which is kind of your practical aspect of medicine, where you learn how to talk to people or patients, where you learn kind of practical skills, like examinations, things like that. I had a PBL tutor, which was my seminars. I had a personal tutor. I had my lectures. So I had about 15 hours of lectures a week, and all of these people needed to get paid. And then there's all the admin staff, there's the people who like run the entire course, who organize everything. And that's before you get to placements, because the people where you go on placement also have to get paid, because they can't see patients in the time where you're there, because they're trying to teach you. So they'll be seeing less patients. So they get paid some money for that as well. And if you're in a hospital, the hospital needs to get paid money for that. They have to fund other things. They have to fund the rooms that they're using. They have to fund the buildings. They have to fund their library, any other resources they're using. So for example, there's online libraries, there's Anatomy TV, which is what we used. They have to fund dissection. Dissection is horrifically expensive because you have to have a whole facility in place for it. This is why many universities stopped doing it. You have to fund laboratories. So if you have actual labs where you go and you do your experiments and you do kind of the more sciencey aspect of this, that's really expensive. They have to give grants to societies that the university runs, and so on. So there's lots of reasons why it's so expensive. This is actually, I was quite surprised that it wasn't higher, but this is a number that's pre-COVID. So it might be higher now with inflation, but that's the last number I could find. Yes, Glasgow has dissection. There's a handful of universities around the country that still do dissection. Glasgow is one of them. One of the reasons why I came to Glasgow. And then COVID happened. So I still got to do some dissection, but not a lot. But it's come back fully now. Good. So next one, the A&E 4-hour target waiting times. So my question is, what percentage of people do you think are seen within 4 hours in A&E? This is for England only, because I couldn't find numbers for the whole of the UK. But in England only, what percentage of people do you think are seen within 4 hours in A&E? wow, this is going to be a positive surprise to you guys. You are not optimistic about this at all. So we're not doing quite as badly as some of you think. Wow, some of you are really close. Good, yes. So we're looking at about 74%, okay? So about 74% of people are seen within 4 hours. Now, in major departments, that means departments in really big hospitals, like for example, here in Glasgow would be the Queen Elizabeth Hospital, which is one of the biggest hospitals in Europe. The waiting times are longer because much more people go there because it's a much bigger kind of catchment area around the hospital of the people who do go there. So in major departments, often the wait is a lot longer than that. But in general, around England, about 74% of people get seen within 4 hours. And of course, you get seen sooner if you have a more urgent concern. So if you come in with chest pain or from a car crash and so on, you get seen immediately, usually. But sometimes people have to wait a lot longer, especially people who are classified as non-urgent. Good. Okay. The next one is a really interesting one. I'm excited to hear your answers about this. There was a study done on medical students wanting to leave the NHS. So what percentage, or as a fraction, if you prefer, how many people do you think are planning to leave the NHS as far as medical students go? How many medical students do you think want to leave the NHS? This is within 2 years of graduating. Okay, I think some of you have seen the study because some of you are spot on with this. So very good question. What do I mean by leaving the NHS? As in going private or leaving healthcare entirely? Any of those things. So leaving the UK to work abroad, leaving healthcare entirely, or going into the private sector. But you can't really train as a junior doctor in the private sector, so you really don't have that many options for going private. Most people leave the country or go into a different sector. Some of you are spot on. 1/3 of medical students have said they want to leave the NHS within 2 years of graduating. Now, you can imagine we have a doctor shortage. This number is not a good number. The government does not like seeing this. So there have been solutions proposed to this, some of them more sensible than others. But that's a number that's hugely concerning to the government, obviously, because if we had 1/3 less doctors than we do now, wouldn't work out particularly well for the NHS. So that's one big concerning thing. But this was a study done, I think, by the BMA, and a lot of medical students participated. The main reason, what do you think is the main reason people gave for wanting to leave? Yeah. Good, yeah. Pay and working conditions was the two big ones. So long hours with low pay, yeah. You have to imagine if you get paid very little, but you work very long hours, but you've worked cheap, trained for 6 years already and been to university and have loans and stuff, then that's a bit of a different consideration to make. So yeah, the main reason they gave for leaving was low pay and stress. What do you think was the main place where people were going to go if they said they were going to go abroad? There was one destination that was kind of the big one. Yeah, good. Australia. So I think about more than 70% said they were going to go to Australia. And then a small fraction was going to leave the NHS entirely, but stay in the UK and work in a different sector. Good. So last one. How many people do you think are currently waiting for elective treatment in England? So elective treatment is anything that's scheduled. It's usually, so this is a number in millions, by the way. So I'm going to give you a clue. Again, this is just for England because I couldn't find whole of the UK data because the healthcare systems are very fractioned. So it's very difficult to find that. Lots of different numbers. No one's come all that close yet, actually. Okay, I've got one that's kind of close. So 4.4 million people, which is a very big waiting list. Most of them are waiting for kind of some sort of trauma or orthopedic treatment, which usually means like things like hip replacements, shoulder surgeries, things like that. A lot of them are elderly, so that's why there's a huge waiting list. I had a question earlier as well. Why do people go to Australia and not to other countries? Because it's really easy to go to Australia and they're recruiting actively from the NHS. The working conditions are good, the pay is good, and it's very easy to switch because they're really very much seeking out NHS doctors. There's actual companies who kind of just put people in touch with hospitals in Australia. It's a whole because it's much more difficult to work in the USA versus in Australia with a British medical degree if you're a British trained doctor, because you have to do exams when you go to the US, but you don't in Australia. No, the UCAT in Australia is different. That's for entry into medical school. So they do a similar UCAT to what you guys are doing or have done. Not entirely the same, but very, very similar. The scoring is slightly different, but that's just for their entry into medical school. But good question. So that's your facts and figures. I'm not expecting you to memorize these, but these are good for context. And these are numbers that you can use, right? So these are on your handouts as well, but these are numbers you can use in your interview if you can remember them. The first one is actually one I used in my interviews, because this has kind of been the same ever, like even 5 years ago, this was exactly the same thing. Okay. So moving on. Looking at the NHS long-term plan. Anybody know anything about the NHS long-term plan or what it is or why we have it? I've given you a clue. The last one was made in 2019. It's also kind of in the name. Yeah, so it literally is just a plan for what to do in the NHS in the next. Oh, anybody know? Anybody know how often we get a new long-term plan? Good, 10 years. So every 10 years, we get a new long-term plan and they give us a list of things of what they're going to improve in the next 10 years in the NHS, what the plan is, what we're going to do, what the main priorities are, okay? So I got some suggestions already of what's on there. So yes, improving the number of staff is a big one, but the first one is about digitalization. It's really about making things like telehealth a big thing, okay? And of course, COVID really helped us along because this plan was made pre-COVID, but then actually COVID, this is one of the few points that COVID actually helped because we switched to telehealth very, very quickly because of COVID, okay? But they're also trying to introduce this in emergency and urgent care, okay? The next one is about prevention and health inequalities. So this is really about things like smoking prevention, about obesity screening programs. So this links in with lots and lots of different kind of current issues and NHS Hot Topics. But also health inequalities, and these are often very specific to kind of local areas. So this is something that they're trying to tackle at the local level very much, because health inequalities are a big, big issue in the NHS. The next one is kind of a bit of a boring one in terms of the name. It's about care qualities and outcome improvement, which really just means improving things like cancer survival. And this means things like, for example, what we just talked about, which is your referral times, or your kind of waiting times for an urgent referral, okay? Improving things like that will improve cancer outcomes, but it's also about things like prevention programs. So if any of you know about kind of, for example, cancer screening programs, that's a big part of that, okay? I had a question about how would telemedicine help in emergency care? So triaging mainly. So things like 111, where you can call in and they can tell you where to go. That's a really big thing. So emergency departments aren't overrun by people who don't need to be in emergency care. And that's a relatively new thing that we have things like that actually. But yeah, they were trying to introduce a lot more of that, and kind of digital appointments as well for like urgent appointments for GPs, for example, so people don't have to wait. Some people don't need to be in A&E, but they also need to kind of see a GP fairly urgently, so they can do a digital appointment for a GP out of hours, for example. But this is all kind of still being introduced. This is not done by any means. Next one is the big one that I got all the messages about, which is tackling workforce pressure. So expanding university places and then new routes into healthcare professions. This is things like your apprenticeships, right? But also international recruitment. So recruiting doctors and nurses and other skilled healthcare professionals from abroad. That's going moderately well at the moment, but they're doing quite well with expanding number of medicine and nursing places. Next one is technology. So again, digital access, including use of AI. So some of you will be happy to hear this, some of you not so much, but this is also why AI has become a big topic, especially in the last year in kind of medicine. And there's many different discussions, and we will do a whole different session just on AI at some point, not as part of this series, but as part of a different series. We'll talk about AI because it's a huge thing. And there's so much to talk about, and it definitely comes up so much more now than it did, for example, 2 years ago. Next is about money. It's always about money. So we're, in this case, actually getting some more money from the government, which is good. It's not a lot more money, but it's some more money. And they're actually proposing that we will save some money through the new model that they're trying to introduce with all of these steps. But we're also getting some more money to make sure that the NHS has money to try and do things like increase the number of doctors. But we're also trying to cut administrative costs and costs in kind of other departments that aren't directly patient care related. This is a 3.4% increase in funding, which isn't huge, but is some. And in terms of kind of real terms, that's a lot of money, really. This is the 2019 long-term plan, not the ones before that. So this is the one that's currently active, because it goes for the next 10 years. This is the one we're currently in. And the last one was about integrated care systems. So we're kind of revamping the way we do medicine. So some of you might know about integrated care systems, but basically what we did is we did away with other ways of organizing care, and we introduced integrated care systems, which are just a different way of organizing healthcare services in an area. It's not super exciting, to be honest, but it's something we can talk about in the future as well. And you can read up on it yourself as well. It's a bit dull, but it's something that you need to know about just a tiny bit, okay? Good. So that's your long-term plan. That's your key points from your long-term plan. Not super exciting, like I said, but it's important for you guys to know the basics about this so you can bring it up in interviews, okay? So carbon footprint really featured into some of these. I think it was mentioned in things like the next steps and also in prevention healthcare, health inequalities. But I'm not sure what exact part of this was really brought up the most in for a long-term plan. You can always bring it up anyway. It's a big one for any part of the UK right now. Any plan that the government makes. So these are made by basically the government, the long-term plan. It's a governmental department that makes these. But they consult lots of people. So these are made kind of, but these are often also, they're meant to be very ambitious. So we know that some of this isn't entirely realistic to implement in 10 years, but they're just kind of something to work towards. Okay. So that's it on kind of the boring data part. Going on to junior doctor strikes. Okay. So you picked strikes, which means COVID-19 vaccinations will have to wait for a different day. But let's start with what we know about junior doctor strikes. Anything that you can remember, anything you've read, anything you've heard in the news. You don't have to be sure about whether it's right or not, but I'll make a list of anything we know so far, and then we'll go through what I think are the big things. And again, you'll get some interesting points. Good. So there's some recent news on this. So recent offer of a pay rise. Good. So this is very up to date. This is actually still being voted on. So there's a new deal that's just being voted on, but there was also a pay rise deal. There was also a pay rise independent of that. It wasn't a very big pay rise, but it was a pay rise. And of that. Good. So it wasn't a 35% pay rise that was negotiated. It was a 35% pay rise that they wanted. It's not what they got. Good. Anything else that we know about junior doctor strikes? Maybe reasons why people are striking or anything else? Or anything you've read in the news about this? Not directly related to accepting more medical students, no. Good, so the big thing was working conditions and pay. Good. Yep, so there was a complaint from junior doctors that's more recent. Actually, that's more so happened after the strike started, but the introduction of PAs, which are physicians associates, being paid a higher wage than junior doctors. Good. So there was a real terms pay cut. Good. Good. Anything else we know about this? So anybody know how much the strikes have cost? This is more of a vague number because there's lots of different numbers published. Anybody have any idea how much the strikes have cost the government? Yeah, a lot is a fairly good assessment. Yeah. Oh, I'm sorry. I know my handwriting is really bad. The first two say that there was a recent offer of a pay rise or a deal, and the second one said the pay rise, there was a pay rise that was offered independent of the kind of new deal. Okay. But you'll also have this more nicely written out on your notes, I promise. 5 million is quite a low estimate. I've got lots of numbers in the million. So the last one says there's a real terms pay cut. This is why I tend to have my slides where I just click through them because my handwriting really, I'm really sorry, my handwriting is really bad. So good, lots of really close estimates, over £1 billion, right? So there's lots of different numbers that get thrown around. There was 1.3, 1.5 billion, some people said 1.7 billion. These are all kind of right. We're looking at numbers in excess of 1 billion at this point, okay? Now, we'll talk more about where this cost comes from in a minute, okay? But these are your basics of the junior doctor strikes, okay? So, anybody know anything else? So anybody know really when the strike started? Because they've been going on a while now. Like, this has not been a recent problem. Good, March last year. So voted on before that and kind of decided before that, but March 2023 is when the strikes officially started. Good. And until very recently, they were still striking on and off, okay? Also during Christmas when departments were very busy, okay? PA stands for Physician's Associate. They used to be called Physician's Assistants, but they've been renamed, so you might have heard Physician's Assistant more than you've heard Physician's Associate. Good, so very kind of recent thing. So they started in March 2023. They wanted a 35% pay rise, okay? It was voted on by, this is a BMA strike, which is the British Medical Association, okay? So the union for doctors. And it was all junior doctors who were striking. So just before we go on for reasons, on to kind of more precise reasons for striking, anybody know what counts as a junior doctor? Who's a junior doctor in the NHS? Good. Anyone who isn't a consultant. So that includes FY1, FY2, but it also includes anybody in specialty training, right? These are people, specialty training can take a long time. If you go into a long training specialty, that includes things like neuro or neurosurgery, it includes rheumatology, it includes plastic surgery, it includes dermatology. You will be training for an excess of 10 years, and you will be a junior doctor throughout that, okay? So during specialty training, you are still a junior doctor. Okay. FY means foundation year doctor. So FY1 and FY2 are your foundation years. That's the first 2 years after medical school. So you finish medical school and you go into FY1. That's foundation year 1. And then you do a foundation year 2. You have to do them. They're compulsory. And then you go on to specialty training. Some people do more foundation years for a variety of reasons. We'll get to that in a second as well, because that's really interesting. Okay. So that's your basics. Okay. Your junior doctors is anybody who's not a consultant. That can be people who've been working in this job for more than 10 years. The strikes were BMA strikes. So British Medical Association, anybody who was a member was on strike. And that's almost every doctor, right? That's almost every junior doctor is a BMA member. They started March of last year. They wanted a 35% pay rise. okay? And they continued to strike throughout the Christmas period, throughout very busy times. There were kind of 3-day strikes, huge deal, okay? And there's currently a new vote going on about accepting a new pay deal, okay? So the other thing we need to know about this is that the messaging in the media was rough, let's put it that way, okay? So you might have seen some of these. Some of these are not very positive headlines, as you can imagine. There were a lot of accusations towards doctors of being very selfish, or risking patient safety. I think there was also a lot of opinion pieces like this one. And of course, public opinion was really split on this, because on one hand, people want their doctors to get paid a fair wage and they want safe working conditions, but they also want to receive care. Okay, so it's really important that you don't see this as a black and white issue. This is something that's very, very heavily debated, and it comes up in ethics questions as well. Okay, so yeah, lots of headlines, some positive, some negative, and this was also something that I think really featured into the reputations the doctors got during that time. So something to keep in mind when discussing in your answers, okay? This is more for your own interest, and this is more to show you that this was kind of a big thing, because not all of you might have been seeing this in the news, but there's lots and lots of different headlines. So I collected some articles during that time, because when I was teaching interviews last year, this was a huge deal, with all the different headlines we were getting every single day about doctors, and some of them were really positive and some of them were more like this, you know. No, you don't need to know about consultant strikes, because they were not a big thing, really. So you need to know about junior doctor strikes, okay? That's all you need to know. Also because at the point where you're going into medical school, you're a really long way off from being a consultant as well. It's the same as you don't need to know about nursing strikes, okay? So going back to the version of this where I don't write, who can tell me, we've collected some already, but who can tell me a reason why doctors were striking? We've got some already, so you can bring up any that we've already mentioned as well. Yeah, so working conditions. This was a really big one, because there's so many unfilled posts as well. Good. So pay erosion. I think the number was 26 or 27% as it was estimated when you take into account inflation since 2010 and 2011. So really a big pay cut in terms of real life things. Working condition goes with understaffing, but good. Yes, so some of these are kind of included in others. So PPE and safety wasn't a big one while they were striking, but that was a big thing during COVID as well. And it definitely contributed to it was kind of the push as well. Yes, bad treatment goes under working conditions. The PAs aren't on this list. It was a reason that came up a bit later about PAs being paid a bit more. Stress, yes. Stress isn't on my list because it comes under working conditions, and so do long hours. Anybody know anything else that might have contributed to people wanting to strike, or some issues that you might face as a junior doctor that might lead you to be unhappy with your job, or the pay you receive, or how you're treated? Yeah, so long career progression. There's one I have that's really closely related to this, so I'm going to give you this one for an answer. That's specialty training. So we have a lack of, yeah, very good. So the next person got it. There's a lack of training places for specialty training right now, which means that you get stuck at that stage where you're an FY1 or FY2, but you can't actually progress into your specialty training. And it's really annoying for people trying to go into specialty training. So it's a bit of an issue because you're trying to become, for example, a surgeon or a rheumatologist or a dermatologist or whatever you're trying to be. And actually there's no training spot for you. Okay. So this makes it really challenging for people to progress in their career, and it's a really long career anyway. So people do more foundation years than they need to because of this. Debt, amazing. So that's my point 8 here. Medical students can graduate with as much as £100,000 in debt, which you then repay during your career. So that's a huge reason why people wanted a pay rise. Okay. I had 2 messages about kind of life being expensive and just expensive. Yeah, So I'll give you increased living costs. Cost of living crisis means everything is more expensive. And if you think about the fact that your pay has fallen 26%, right? And then living costs are suddenly more, and food costs more money. At some point, it becomes too much. Okay, good. One good point. This is not on my list, but this goes under working conditions. But it's a really good thing to bring up. When you apply for your foundation year training, you get moved to a random place in the country. You have some say in it. You get to make a list, you get to rank everything, but it doesn't mean that you definitely go where you want to go. And there's people who've gone very far away from their families, who've gone very far away from their support network. And that's definitely something that contributes to people being unhappy with their job as well. So it was random before as well, essentially. It's just before it was based on your exam scores. Now it's just based on giving everybody the highest preference that you can. Good. Why is it randomized? Because we need doctors all over the country. So you can rank your preferences, but then you just get assigned a job, essentially. It's just because otherwise it wouldn't work. It's such a big country and such a big system. Very good point. The amount of tests that you need to pay for. This is a really good one. I didn't think anybody was going to get that one. So you get bonus points for this one. Exams and further learning. So I found a really old paper on this because I couldn't find any more recent data. But there's a 2011 paper that tells us that we spend about £17,000 on exam fees and other preparation material related expenses once you finish medical school. That's a lot of money. £17,000, a lot of money. Anything else? There's two more. The two that I've got left are kind of tricky. I had a very good point about it being based off grades. The other thing with it being based off grades is that some areas in the country got a bad reputation for having bad doctors. So it was also just a thing where people were like attracted to certain areas because they said, oh, this is where all the people go if they have a high kind of score in their exams and so on. So it just wasn't a feasible system in the long run. Work-life balance. Paperwork and admin isn't actually a point on here, but it did make junior doctors unhappy. It's one of the reasons why we got PAs. The long training pathway, actually not so much. It's more the student loans that come with it, but yes. Work-life balance goes with working conditions. There's two really specific ones that I have left. So one of them, I'll give you lack of support. I'll give you widening participation. Okay. So you might know that there's lots of widening participation schemes to get into medicine, but most of these stop once you're in medical school or once you are a doctor. So these are often people who have a lack of a support network at home, or they have, they now have high loans because they have to take maximum loans. They might have taken private loans as well. And now there's no support network left for you. And that's a really big issue of junior doctors as well, because obviously you get moved around the country, and that's really expensive. And often people have family that helps them with this, just helps them move, helps with stuff like that. And people who come from widening participation backgrounds are less likely to have that. Okay. There's less of a hierarchy in medicine now than there used to be. Actually, it's not one of the big complaints anymore, but there's definitely still parts of this that do still exist. So it's not entirely good, but it's definitely improved. The last one is professional memberships. I wasn't expecting anybody to get this one, but you got all of the others, so that's really good. Professional memberships are really expensive. And these are things like the BMA, which is the British Medical Association, which is the union for doctors, or the kind of big union. There's other ones as well, but they're much smaller. The BMA is the big union we have for doctors, and the contribution you pay to them increases as you go through your career, but it's actually quite big. So I don't pay this much. I don't think I pay for it right now because I'm a PhD right now, but I used to pay about £3 or £4 a month, but once you become a doctor, this massively increases. So all of these figures are per year, by the way. This is not per month, this is per year. But you pay about £126 per year in your first year. You don't have to be a BMA member, no, but it does offer you some protections. And it's something that most people do because you need their advice, you need their help, you need their training. So you can get away with not doing it, but your life gets a bit more difficult if you aren't a BMA member. You also get access to things like the British Medical Journal and stuff like that. The GMC you have to be registered with because that's the kind of regulatory body for doctors. So you have to have that. That starts at £25. It goes all the way up to £455 per year. Then there's MDU and MPS, which are your legal protection. That's one that you don't technically, I think, need to have, but you really should have. So they are, if you get sued, they protect you. If a patient tries to sue you, that's who you go to, and they will try and fix it, essentially. They will provide a lawyer for you. They will go to court for you. Why is such a big range for a GMC? Because the first year, your provisional registration year, you pay a very small amount. You only pay £25, and it goes up rapidly for kind of once you stop being in your foundation years. It's just because in the first year you get a discount because you have so many other expenses. That's actually quite good, but it's just the first year. I had a really good question. If you have to be registered with the GMC, why would you have to pay for that? You just have to. It's just always been that way. So we have to pay for it. There's no way around it, unfortunately. It's an expense that you have to carry yourself because the government won't pay for it. So you'll have to pay for it yourself. It's the same in some others. What if you can't, then you don't get registration. So yeah, there's really no other option. You got it, unfortunately. Some of the others, what do they use the money for? So they use the money for lots of stuff. They use the money to essentially regulate doctors. So they might be they do things like regulate doctors that have broken the rules. They have tribunals. They make sure everybody's adhering to the rules that they set. They make guidelines and so on. Had a very good point. So you have to be able to afford to be a doctor. Yeah. And this is why junior doctors were striking, because it became a profession that you have to be able to afford. And that's not the purpose of a doctor or of a job, really, that you have to be able to afford it. So especially in the beginning, these are huge expenses. So yeah. And then there's professional colleges, so like the Royal College of GPs, for example. So yeah, and then going on, kind of they cost between a couple hundred to a couple £1,000 a year if you're registered with a kind of college for a specialty, which is not something you have to do, but you can do, and it helps. Is it possible to do your general years here and then do FY1, FY2 somewhere else? So I don't know what you mean by general years, because there's no doctors before FY1, FY2. You're a medical student before that. You can do medical school here and then leave, but most countries won't accept you before you've done at least FY1. So I think you need to do FY1 at the very least in the UK for almost every single country, and then FY2 for most of them as well, because you're only provisionally registered with the GMC. You only have a provisional license when you graduate. So these are the reasons junior doctors are striking. I know this looks incredibly depressing. I promise you things are improving. That's why people are striking. This is why I think as medical applicants, as medical students, we have to be very supportive of people who are striking, because they are trying to improve things for all of us and for the people who come after them as well. Okay. How do we bring this up in interviews? I'm so glad you asked. We'll talk about that in a second. Okay. So this is the slightly depressing graph of the earnings of a junior doctor and how it's gone down. So you can see there's kind of your overall junior doctors here, just this line. But then things like the foundation year 2 doctors have seen the biggest decrease. And these are just kind of your observed earnings versus your expected earnings. And this doesn't take into account everything, but it takes into account of inflation, I think, only. So yeah, not a very optimistic kind of looking graph, but just for interest at this point. Now, let's look at the other side of things. What are the negatives of strikes? Why shouldn't junior doctors strike? There's 3 big ones. Good, patient impact. I'll give you patient impact. So what about patient impact? When you say affects patient care, be more specific. How does it affect patient care? What is the problem? Good. I'll give you public trust for saying patients' view of the NHS might change. Appointments are cancelled, longer waiting times, wait times increase. Okay, I'll give you patient impact. reschedule appointments, right? So people, their operations get moved, their, pretty much everything, really. Clinics get moved, appointments get moved, anything that's not urgent gets delayed, okay? There are still doctors. It's important to me that you understand that there's still doctors on the ward. The hospital isn't empty. There's people working. A&E is covered, emergency medicine in general is covered, including trauma and orthopedics. There is kind of emergency stuff. Everything is happening. ICU is staffed, okay? It's not that there's no doctor in the hospital, but it is only emergency services. It's only what needs to happen. So anything that's elective, anything that's scheduled doesn't happen. So everything gets rescheduled. Then the people who are there, there's a minimum staffing level. It's kind of the minimum that's safe. That doesn't mean it's a great level. So they have to wait longer, okay? Quality of care is lower, okay? That's a big thing, mainly because waiting times are longer and because appointments are rescheduled. So it's a whole kind of, it all adds up together. And then the health outcomes, the both long and short-term health outcomes are worse because you have to imagine if you don't get your surgery right now, then that's not good for you. It's not good for your health because you needed that surgery. It wasn't being done for no reason anyway, So that's both long and short-term health outcomes that are worse. Good question. Is it covered by consultants or non-striking junior doctors? So some of it is covered by locum doctors, but most of it is covered by consultants who are also working as locums in that time. They get paid huge amounts of money for this because you have to pay them really good money for them to be able to, for them to want to work those shifts. So some consultants got paid atrocious amounts of money for this. There was one report of a doctor getting paid £3,000 for one shift. That was an exception, of course, but there was big money involved in this. Which brings me to my next point. Cost. Super expensive. Strikes were super, super expensive. So who can tell me about the public trust aspect and the cost aspect? Why is it expensive? And, I've got some points of cost actually already. So why is it expensive? What's the actual expense of it? And why is public trust an issue here? So for costs so far, I've got direct cost of cover, I'll give you, because that's the cost of locums. Yeah, good. Anything else on cost? Yeah, so direct cost of cover. So that's the cost for paying locum doctors and paying the consultants to cover the shifts. Then you have to catch up on the backlog. And some of this is covered by your by the doctors that are working in private health. Okay. So it's not always something that the NHS is catching up on, but sometimes they actually pay a private hospital to do some operations. Okay. Good. Yeah, good. So I'll give you the other one as well. So we're catching up on the backlog. The other thing is opportunity costs. So this is, for example, training for junior doctors, right? They miss out on their training, which needs to be caught up, which is expensive. Okay. Public trust. The NHS is an institution. People lose trust in that because they say, oh, like doctors don't care. The NHS doesn't care. The trust in the politicians and politics in general decreased during the strikes. And then, of course, trust in healthcare professionals and in doctors, because they're saying, oh, the doctors care more about getting paid than they care about actually helping me, which was a really big issue. And I think this is why it's important that when you're talking about strikes, you also take into account that actually doctors weren't just striking because of pay, they were striking because of many factors. And one of them was wanting better patient care for their patients. Okay. Good. Really well done on this. Now, the interview question I can come up with this is, would you participate in the junior doctor strikes, right? There's many, many others with this. So there's many more on your handout as well, but this is kind of the big one. So would you participate in the junior doctor strikes? Okay. What does backlog mean? It just means anything that's basically like the list that we've now got of everything we didn't get to do. It just means kind of the waiting list, essentially. We've created a waiting list as part of this. So the people who didn't get to have their clinics now need to have new clinics, but we don't have space for them in the current clinics. So we have to create new appointments for them. It's just it creates whole new issues. So your interview question is, would you participate in the junior doctor strikes? Now, this is something I'll let you think about by yourself. It's important, much like in ethics, that we don't start before conclusion in our answers here, right? So don't open up this question with saying, I would never participate in junior doctor strikes because I think they're awful, or saying, I would absolutely participate in junior doctor strikes because I think it's the only right way to go forward. always start with a balance point. Say, this is a really difficult question because there's lots of things to consider here. First, I would consider the negatives of the strikes, and I would consider the impact on patients. I would consider the cost of this and the impact on public trust. But I would also consider the reasons that junior doctors are striking and the positives of strike, such as improving working conditions, improving pay for junior doctors so they can cover costs, like the costs created by exams and further learning, their student loans, and professional memberships. Okay? Present a balanced argument, much like in ethics. Okay? Does that make sense? Do we have questions about our pros and cons of strikes so far? How is this marked? So these questions are always marked in kind of a very similar way. It's always about trying to see if you can appreciate both sides of the argument, if you make valid points, and if you can apply reason and come to a conclusion. Okay. There's no specific mark scheme that stretches across all universities, but there's kind of a general mark scheme for all of these. Yes, we can absolutely, I'll cover some of the benefits of strikes, of course. Okay, so just last slide. This is currently still ongoing, so keep an eye on this, and you can look this up every few days. I looked at this yesterday again. So we've got a new pay offer. I think it's quite good. It takes into account a pay rise that they've already had, and everything. So it's not. It sounds like a lot of money because it's saying 26% or something like that, but it's actually not quite as much because it's taken into account the pay rise that we've already had. But it is still a lot of money, and it's still a lot better than anything they've been offered before. So the BMA has recommended that it's going to be accepted. And we will see if it's accepted. And if it's accepted, then that's the end of strikes. And that doesn't mean that strikes are not going to be a question at your interviews. They will still be a question, even if the strikes end. Okay. But it does mean that the strikes can come to an end, and that would be good for everybody. I think we can all agree on that. Okay. So that's it on junior doctor strikes. We've actually managed to cover it in the time, so I'm really happy. Like I said, vaccination we'll do some other time, and COVID-19 we'll do some other time. But I'll go through any questions you have. But also, just before we do that, these are the links for reviews. I put up, I think I sent you a Trustpilot link yesterday, and some of you used that, and thank you so much. It really means a lot to me when we get reviews. It's really good for us, and it means I can do things like this. So if you're enjoying these, if you find these sessions helpful, then please let us know, so we can do more of them, and I can do more of them. But yeah, would really appreciate that. I'll cover any questions you have. So you asked about the benefits of striking. So benefits of striking, the big thing is kind of the impact on patient care and the pay, right? So it's everything we've talked about before. It's our, sorry, that's vaccinations. It's our key points from here that you'll have on your handout as well, right? So junior doctors will be able to cover costs like their cost, the increased cost of living, their professional memberships, the costs from exams and further learning, their student loans, and it will help those from widening participation backgrounds. Okay. The other thing is working conditions, so this improves patient care. Okay. And the other points are ethical points that you can also think about. The recording will be up on Notion and the Google Classroom as always. It should be in the same place where all the previous recordings are. Okay. Good. Does that mean junior doctors can never strike again? No, it doesn't mean they can never strike again, but it does mean they wouldn't be striking again in the kind of near future. Okay. But it does mean kind of for right now, there will be an end to the strikes. I had a question. Do you mind discussing what the other interview sessions will include, the separate ones? So I'm the person who's writing all of these and who's making all of these, who's kind of doing the interview stuff this year. So I'm still deciding on what we're actually doing. It's up to you guys to a certain degree as well, right? So if you guys have anything in particular that you really want me to cover, then absolutely let me know right now, because I'm still planning them. but we will do other things, like mainly we will do many of hot topics. We will do things like role plays and cover kind of role play questions and how to cover those. We'll cover scenario questions, a bit more on ethics because we've only done an intro. We'll cover a bit more on kind of reflective questions as well, and then a bit on panel interviews as well, because some of you might be going to panel interviews. So I'm still planning what exactly we're doing. Do staff still get paid while striking? No, I don't think they do. I don't actually think you get paid during strike action. It's a very good question though. I'm not 100% sure, so I will look that up. But I don't think they do. What do you think will happen if the offer isn't accepted? Will doctors strike indefinitely go on a longer amount of time, or are they legally allowed to stop working? I think if this pay offer isn't accepted, then there will be more strikes. And I think that will be very, very bad for everybody. So I do really hope this is accepted, and I think most people are hoping this will be accepted. But yeah. So there will be a different interview program that's running. This is just the intro to interviews. So these are 4 sessions that come as part of your UCAT program, really. And then there's a separate interview program that will run with like interview tutors and interview mentor groups and so on. That's a completely separate thing. So that doesn't have anything to do with the UCAT stuff we're doing right now. This is technically still part of your UCAT prep. Okay. When would they take place and how much would they cost? I'm not involved in the cost aspect of this, so I'm the wrong person to ask, unfortunately. But I know that they will start around October time. When concluding on a question on ethical topics like strikes, how do you decide if it's good or bad? Good question. So it's your personal opinion, right? And it's based on your balanced argument. So you have to decide if this is something that you think is overall, if you have more good or bad arguments, like, or more pro or con arguments for this, really. So that's how you decide, really. It doesn't have to be, there's no right answer. They just want to see that you can appreciate both sides, really. Do most unis have panel interviews? No. So some unis have panel interviews, like Glasgow and King's have started doing panel interviews and so on, but most universities have multiple mini interviews, which is the main thing that we're covering in interview prep. But it will be kind of one specific session that we're going to run, hopefully, for panel interviews, just for those of you who are going into panel interviews, because it's slightly different. But most of the sessions will cover kind of general stuff and then kind of MMI heavy stuff, because all of you will be doing MMI interviews, but not all of you will be doing panels. Could the BMA be taken to court like with the nursing strikes? Good question. I think not, because the strikes were done in a very kind of legal way, but theoretically, yes, they could try. When will we find out about the extra interview prep? So I don't know yet, because this is not my thing. But I know I'm starting to write the sessions right now. So you should be finding out by kind of the UCAS deadline at the very latest, but usually early October. And you should be kind of told what the sessions will be exactly, when they will take place, if there will be recordings available anyway, and usually handouts. Do you guys find the handouts helpful? Is it something that we find helpful? Okay, good. I just don't like when you guys are just focused on taking notes instead of listening, because I think this is so much more fun if you guys get to interact and actually listen. Good. So in which part of MMI interviews would these NHS topics be asked? So they would ask you about something that you've read in the news recently about the NHS, or about things like strikes in AI in medicine. They can just ask you directly. They would ask you, tell me what you know about the junior doctor strikes. And it would just be its own station on current issues. What are MMIs usually like? Is it more talking or more activities to test skills? So they are really about, they're different. It depends on where you interview, but some of them are more skills and quality-based questions, which is what we'll do next week. So they're more about asking you, tell me about empathy, tell me about communication skills. Some of them are role plays, some of them are task-based. So they're asking you to do something. They might be asking you to describe a graph or a picture. They might be asking you to describe a patient scenario. They might be asking you to do a number of other things, really. And some of them are based on your wider reading. Some of them are based on hot topics. Some of them are based on ethics. And this is why you often have like between 4 and 8 stations, or even 10 stations, where they test different skill each. Some of them, very few of them, include maths, for example, as well. Do we know what is in each station of the MMI? Some universities, yes, but most of them, no. But you kind of know from like previous years, so you'll have a good idea of what kind of comes up, but you won't know exactly. And they would there's only 1 or 2 universities where they actually tell you what the questions will kind of be. Everything else, you just go into it kind of blind. So you should be prepared. How should you prepare for wider reading? For wider reading, it really is about knowing what you've read and being able to reflect on it, being able to talk about it comfortably. So that really means trying to have a good, so looking back on what you've read just before your interviews as well, and trying to have good key points from it so you can summarize it well, but also having good reflective points. So something you've learned from it. Okay. In the future, we'll talk more about reflection and why it's such a big thing that gets you so many marks in interviews. But so far, kind of in ethics and in hot topics, it's not a big a topic, reflection, but when it comes to kind of personal skills and qualities, reflection becomes really big, and it's kind of the thing where most of your marks come from. So it's also difficult to do it right. But once you get it, you always get it. Okay. Good. Okay, that's it from my side. Thank you all so much for coming along. You're a great group. You interact so well. It's really, really lovely to teach you because you all have so many questions and you always have something to contribute. So thank you so much for that. If you can leave a review, please leave a review. But other than that, have a lovely week. Have a lovely rest of your Sunday. And I will see you hopefully next week when we talk about personal skills and qualities. So universities don't usually give out the questions ahead of time, even with accessibility reasons. So they wouldn't give them to you ahead of time, except if at universities where they usually do already, because it would create an unfair advantage in comparison to other students. But it can be that you have time, it can be that you have more time for a station, that you have reading time before them at some universities. So that's something to ask about. And I would email universities right now to ask about things like that. Because some universities will be more happy to accommodate you than others with things like that, depending on how the university runs, or how the university runs the interview as well. So definitely ask. Okay, thank you guys.